Thank you very much. So I again appreciate the invitation to come and join you in the symposium. And this afternoon to talk about some of the new valves that are being used clinically. After this morning's discussion about tissue-engineered valves, this is going to sound like Jurassic Park, actually, in a way, but this is what the state of the art is in terms of clinical application. That's my score. I think yours was 27.
Yeah, two is too low, isn't it?
No, that was about right. I'm a very honest guy.
You must have lied about something.
All right, there we go. So I'm going to speak to you this afternoon about the results of the FDA early feasibility study of the Harmony transcatheter valve supported by Medtronic. I think we're all aware of the background for the need for large size valves in patients with Fallot's tetralogy. The problems with Fallot's tetralogy and pulmonary insufficiency has been detailed in the symposium earlier yesterday. Although surgical placement of bioprosthetic valves is a very effective solution, it does require a relatively high invasive approach. And the Harmony valve was designed to provide a less invasive implant for the treatment of patients with large right ventricular outflow tracts. So sort of give you a notion of what the horizon is for patients with RVOT disease. This sort of diagram outlines in a cartoon fashion the anomalies of the right ventricular outflow tract. And in terms of the application of the diameter of the valve that's applicable for the Melody valve, which is, as you know, an outer diameter of 24.5 millimeters, an ID of 22, it's only about a quarter of the patients that we see that have RVOT disease. 3/4 of the disease actually have outflow tract dimensions that are not applicable for Melody valve or even the Sapien valve implants, and thus the design of the Harmony implant. Now, I apologize, this slide's a little messy, but this is just to give you an overview of how this valve is constructed. The valve that was used in this study was an asymmetric valve with the pulmonary artery end measuring about 33 millimeters and the right ventricular end measuring 42 millimeters. It's 5.5 centimeters in length, and this is sort of with the valve closed. It's a treated porcine pericardial valve, so very similar to the bioprosthetic valves that are implanted with a 22 millimeter diameter. The delivery system is 25 French, and a very typical delivery system if you're familiar with implants for AAA grafts. So it's this is self-expanding design, and it's compressed onto a rotational device that allows you to open it up and remove it. And this is sort of an implantation in a SLA model just to give you an idea of how this implant is delivered. And then the attaching mechanism is just unscrewed and the device is implanted. So the overview of this particular study was a non-randomized prospective study. It was the first FDA-approved early feasibility study under that system, which has now become the standard for device implementation or device approval in the United States. The primary objective of this study was really an engineering study to understand the loading conditions of the implant in the right ventricular outflow tract. So it required some additional imaging after device implantation, which we'll talk about in a moment. The secondary objectives obviously were to determine procedural safety and feasibility and overall valve performance, and I was very fortunate to be one of the three centers involved with this study, John Cheatham and Lisa Bergeson from Nationwide and Boston Children's were the other two co-PIs. As in any such study, there was a DSMB board and a screening committee, very similar to how the aortic valve implants were assessed, a screening committee to determine whether these were appropriate candidates. So the primary objective, as I mentioned, was to look at the engineering aspects of the device in vivo, because there are no real good animal models that represent the right ventricular outflow tract in a Fallot's population. And it required a CT scan to be obtained within a week or so after implantation, looking at various components of compression and bending and torsion of the device in vivo. And the secondary objectives were the procedural success, device-related adverse events, changes in right ventricular volumes, whether or not there was regurgitation, and obstruction. Very standard approach in terms of inclusion and exclusion criteria. I won't go into the details, but all the patients had to fulfill criteria for a standard surgical valve implantation. In other words, they had to meet criteria for pulmonary valve need. We obtained a dynamic CT scan, and it was actually protocolized to require the dual source CT scan in order to obtain both systolic and diastolic dimensions from a single beat, unlike the MR, which is an addition of a number of beats. And this was because we wanted to make specific measurements of the changes in the pulmonary artery dimensions during the cardiac cycle. And I think it's very interesting to note, if you just keep an eye on what happens to the dimensions of the pulmonary artery, the main pulmonary artery, during the cardiac cycle. And this has great impact on this kind of a device, which requires compression, or as the engineers call it, interference, in order to keep it stable. There's no hooks, and it doesn't take up the entire space of the outflow tract. It requires the device to be compressed within the landing zone. So the CT scan was made, and then an SLA model was created in order to do a virtual implantation in our mind's eye of what we thought the position of the implant would be in patients who fulfill criteria for the dimensions. And this is a systolic and a diastolic frame from one of the patients that I enrolled in the study. And you can see the changes in dimensions. This is during ventricular systole, and this is during ventricular diastole. So you can see how dynamic that area is and how it would interfere, or issues that you have to be concerned about picking the device diameter. In this case, we only had one device size, so we actually had to find patients that fit that device size. So that was one of the issues with the patient numbers, as we'll see. And I guess the next question is, how do you choose a device and how do you assess the compression that would make the device stable? So a perimeter plot was made at various levels throughout the length of the main pulmonary artery. And this line diagram is the perimeter plot of the device. So this would be a 33 millimeter diameter here, and this would be a 4 millimeter diameter here, but this is the perimeter. And then if you then take your angiographic or CT data, this would be the main, from the bifurcation down to the origin of the right ventricular outflow tract during diastole. And you can see that during diastole, the main pulmonary artery actually gets smaller. So that would be represented here, and there would be a lot of compression of the device. Similarly, at the right ventricular end. And then during ventricular systole, when the main pulmonary artery expands, this would be the perimeter of that area, and you'd still have a degree of compression, both distally and proximally. And there was an a priori decision made that we were looking at 15 to 17% compression at the two ends in order to have a stable device. So this was a set of angiograms sequencing the implantation. Of course, we look for the coronary arteries. The implantation, I have to say, from a technical standpoint, other than for a couple of little tricks in understanding how this device works, really isn't the most difficult part of the project. The most difficult part of the project is any of you who are doing these large valve implants is identifying the right patient and the right anatomy so that it will become successful once you go through the stages of the implantation. Multiple angiograms are obtained during implantation. You can see the carrot is in the left pulmonary artery with a heavy exchange wire. This is the device here being slowly opened as the external cover over the delivery system is retracted, very similar to the ensemble, and then ultimately the area that is unscrewed. And then the next trick about this implant is to remove the delivery system without catching the distal end of the implant, so you pull it out. And it was actually John Cheatham, who had come up with the change in how to remove this device. I'm not going to tell you the trick because you might use it for your device. But one of the major issues of concern, of course, is once you've implanted a device which requires compression for implantation, you don't want to remove your delivery system and pull it back. And then this is the device implanted, competent, with minimal amount or no perivalvular leak. And this is an ICE catheter after implantation, so you can demonstrate the movement of the valve leaflets in the absence of regurgitation or significant stenosis. So what were the outcomes of this overall study for this sized device? And anybody who's doing these kinds of devices understands the problem with patient identification. I think we went through about 300 or 350 patients, the three centers, to identify about 60 or 67 patients who we thought as operators would be appropriate for this device. Of the 67, only 23 were identified as actually being anatomically appropriate. So that even so 2/3 of the patients weren't sufficient, although we thought as operators they might be. 21 patients were catheterized. We had 20 implants. We have follow-up of over 2 years, 2.5 years, but most of the patients had gotten through their 12-month follow-up, which is the data that I will be going over with you. The mean, most of the patients, the mean age was 25 years. Most were male, weight was about 70 kilograms, and a variety of lesions or defects as you would have expected in this population. So what the results were from the outcome of these 20 implants with the 1-year follow-up, the Harmony valve conformed very well to the outflow tract anatomy. There was the anticipated compression both proximally and distally at the ends of the implant, and this compression facilitated device sealing. The central housing was not compressed by the main pulmonary artery. Of course, you don't want that to occur because that would interfere with the valve function. There was minimal lengthening or shortening the device throughout the cardiac cycle, overall less than 3%. And there was cyclic deformation of the device or twisting, but it varied considerably based on any given patient, ranging from 1% to 37% during the cardiac cycle. And this is sort of a line diagram of the kinds of compression that you would anticipate. So here is the device during ventricular diastole. So this is the smallest pulmonary artery diameter, and this is the unconstrained device, just laid on top of the, or overlaid on top of the outline of the main pulmonary artery, and this is a frame from after the implantation, and you can see, for example, in this spot here, how much compression there is in the patient, in the outflow tract. And these are just overlays of the systolic and fully expanded and compressed outline of the stent in diastole after implant and systole after the implant, showing that the device was being compressed at different spots throughout its length during the cardiac cycle. The hemodynamic outcomes were as one would expect for a competent implant, with a reduction in the right ventricular volume, systolic and diastolic, and near elimination of the regurgitation. The follow-up at 12 months, while 95% of the patients had severe pulmonary regurgitation, none had severe regurgitation, and only 6% had mild regurgitation at 12 months. Similarly, paravalvular leaks, of course, a concern where you have the device being compressed only proximally and distally and not throughout its length. There was either none or only trivial in a quarter of the patients identification of valve leakage. And most importantly, there was a slight increase in the gradient across the outflow tract over the year, a mean of 10 to a mean of 17 millimeters of mercury throughout the outflow tract, some of which is related to the way the echo Doppler assesses a non-stenotic or a stenotic outflow tract, or a stenotic non-compliant area, as you're, I think, well aware of. There are adverse events in anything that we do. In this population, they were adjudicated by a clinical events committee. There were 5 events, or 5 patients experienced 12 events. The majority were minimal, with 1 major stent fracture and 2 patients requiring operation, both requiring explantation and a surgical valve. No reinterventions have been required up through the year, but 1 patient whose echo suggested they had a high gradient had a diagnostic catheterization, only to confirm that the gradient was sort of related to the echo Doppler flow dynamics, as opposed to what the true right ventricular and main pulmonary artery pressures were. So in conclusion, the Harmony valve was successfully implanted in position in 20 patients with large right ventricular outflow tracts who suffered from significant regurgitation. 2 patients required explantation at 1 year, but overall there were significant reductions in RV volume, persistent elimination of regurgitation, and minimal paravalvular leaks, suggesting a clinically relevant device for this population. The valve housing were maintained with minimal deformation during the cardiac cycle or shortening. Adverse events which do occur included device fracture and migration, but the information from the loading conditions from this study improves our understanding of the behavior in vivo, which will contribute to further design of the valves going forward, and it acknowledges the very significant complex anatomy of the right ventricular outflow tract, which require a variety of different device designs and dimensions to address this very large patient population. So again, thank you very much.